Okay, well, hello everyone, and welcome to another session of Virtual Global Spine Conference. I'd like to welcome everyone, and I'm on behalf of our co-hosts, some of whom are with us today, as well as our terrific virtual spine panelists. I'd like to welcome everyone. We have on the schedule today Dr. Christoph Hofstetter, who's really an internationally renowned spinal endoscopist, if you will. He's a neurosurgeon who's very adept with spinal endoscopy, and we're looking forward to having him join us and show us some of the pearls and tricks that he uses. He's absolutely fantastic. I am told that he is. Hopefully, he will be joining us soon. Perhaps there's some technical glitches, but what we'll do is I will go ahead and just talk about a slightly unrelated topic, but we'll start with a few slides on in the spirit of keeping the discussions going. We'll go ahead and share some slides and some thoughts on something that I do quite a bit, which is occipital cervical fusions. Oh, no, never mind. Here we go. I think we do have Dr. Hofstetter. Good, you saved us. So let's get him in here and do the proper introductions. There we go. Yeah, who is it? Yeah, Aaron, I think Dr. Hofstetter is with us under Koi Tan.
I made him a co-host, so he should be able to speak and share.
Great. So Dr. Hofstetter, welcome. I guess you made my life easy. I was going to have to present something. But thank you for joining us. I'll do a proper introduction. Dr. Christoph Hofstetter is a neurosurgeon at the University of Washington in Seattle. As I mentioned, he's an internationally renowned neurosurgeon who specializes in spinal endoscopy, really one of the leaders in the field. And we always learn, all of us really learn a lot when we read some of his work and hear his talks. And as I was saying before you joined us, you're obviously one of our special guests because you were with us, I think, on the very first webinar that we did a year ago when we got Zoom bombed, and we all felt terrible about it. But then if you remember, that was a time where everybody got Zoom bombed too around the world, so we didn't feel too bad. But here we are a year later with the phenomenal faculty co-hosts and a new addition who are the panelists, and we're still going quite strong. We're doing this every Thursday, so we're happy to welcome you back, and we're looking forward to your talk on spinal endoscopy. Welcome, Christoph. Thank you for joining us.
Perfect. Thank you so much. Sorry, I'm just getting my charger here right now. Just Ali, thank you so much for the kind invitation. Really cherish being here right now. As everybody, crazy day today. I have a T10 to pelvis running, and I just finished my clinic here right now. So that's kind of my day today. So anyhow, but we'll not talk about T10 to pelvis today. So we'll talk about endoscopic spine surgery. And I'm super excited to do that. Can you guys see my screen?
Yes, it looks great.
Perfect. Yeah, it's your logo on that. So I'm very proud that I found that. And so perfect. So again, thanks for having me. Super excited. So my disclosures, I do some teaching for relevant for this. I do teaching for TroyMax, and also with AO, we work with Wolf. So I'm involved with these kind of technologies, but I do the entire spectrum of spine surgery. Again, as I told you right now, I have a T10 to pelvis deformity surgery going on right now as we speak. So we do tumors, deformity, everything. This is a part of the practice, but definitely not everything that's needed for a spine surgeon. Here are the objectives, and I want to touch upon those. I want to understand, I think really sort of bring forward that the benefit of endoscopic spine surgery is complexity dependent. So how complex the problem is. I want people see what's right now established, and I think what's well proven indications. And then I want to sort of also show where it's extremely useful in my practice for very complex issues. And then, it would be cool to kind of see where you would envision this would fit into your practice. So that's kind of the objectives for today. very quickly, so on the right side, you see every fellow gets, a T-shirt at the end of the fellowship, and obviously an endoscope has to be on it. So this has been one of our very, very nice fellows who kind of like was very, silent, but very, very, persistent, and he has become a fantastic, complex spine surgeon now. So first, why do we do that? That the answer for that comes from the traditional spine surgery, a study by Jens Chapman, 1,500 patients they analyzed, and they looked at, what are the factors that determine whether you have a complication or not in your surgery. And they looked at all different kind of factors that they looked at: age, gender, smoking, you name it. They looked at everything. But interestingly, the only two factors that they found contributed in the end to complications was the age and the surgical invasiveness. And that was in 5 out of 6 organ systems. With other words, if you had surgery, then those two factors, if you're older than 65, or if there was a more invasive type of surgery, were really the main predictors for having perioperative complications. And I think that's really a great underpinning for that effort that has been led by Dr. Hartl. I think he has been, presenting in this forum too. And even though I'm not a big friend of the definitions, I think everybody all the time tries to be an MIS surgeon, in that it's a technique and a procedure that reduces the local operative tissue damage and systemic surgical stress. With other words, if you use the aquamantis, for example, or the bipolar sealer, and you decrease blood loss during a deformity surgery, yeah, that is per definition MIS surgery. So because it's an organ system. So keep going forward here right now. So couple words about low complexity procedures. So low complexity procedures for me are like, entry models of cars. If you buy a Corolla or like a A-class Mercedes, which they don't even sell in the US, it's really, there's not much excitement for going for the premium car. And it's very similar for the endoscopy too. So here's like an example of a 29-year-old female. You see a massive disc herniation. And that's kind of what you see intraoperatively. So that's an interlaminar approach. So yellow ligament, we go through the yellow ligament there, get into the epidural space. You can see how the irrigation pushes neural structures nicely away. And then you're going to get, so here's rostral, here's caudal, here's lateral, here's the thecal sac here, this approaching that disc herniation here. And out here is the S1 traversing nerve root here right now. And then the disc herniation is right there, and we're ready to take it out. So that's kind of the view that you get from a interlaminar discectomy. As you can see, the visualization is just superb. That would be an interlaminar discectomy. Again, we have, with the AO, we have established a nomenclature system, which I would encourage everybody to use, so that we can build a common body of studies and knowledge around this field. And this is another way to take out a disc is a transforaminal into endoscopic lumbar discectomy, also something we call TELT. There's a couple of pictures from a book that we wrote. And here's an example for that. So that I did just a couple of weeks ago, 23-year-old athlete. He had this disc herniation, as you can see, massively downwards herniated, almost reaches L5S1. So you can see that. And so this one we did transforaminally because it allows you to get that caudal extension there. And so you drill a little bit of the SAP here. Again, here's caudal, here's rostral. That's the SAP, so the pedicle of L4 will be right here. We're going to see it in just a moment. So that's the L4 pedicle here. Sorry, it's of course the L5 pedicle, I apologize. So L5 pedicle, so you see the arch here coming up. Again, here's dorsal, here's ventral. I always like to see the neural structures first. So this step can be done blindly too. I'm not a big believer in that. I like to visualize all the neural elements like we do in classic surgery. And here we take out the disc herniation, which is sizable. It needs to be sizable, obviously, otherwise nobody's impressed. And so taking out the disc herniation. And then again, we keep forward another fragment And then what we see in the end is like the traversing nerve root, exiting nerve root starts right up there. Annular defect, you can see there. Typically, we char that area. The South Koreans call it a annuloplasty. I call it nothing. And in the end, you can observe here the traversing nerve root in there. You can see that's the traversing nerve root, which nicely came back into the area. You can see it pulsating, and it's entirely decompressed and visualized. So that's the quality of full endoscopic spine surgery that we expect nowadays. So full visualization of neural elements prior and after the decompression. And he's only 3 weeks out. Again, he's an athlete. We are tracking our patients now with an app. And so you can see, interestingly, almost all patients have, some flare up of back pain roughly a week after surgery. It might be that the exparel wears off, but, he's doing otherwise really well. So no more pain medications. His leg pain is subsided. He says like it's a 1 right now. And so he's recovering wonderfully, and he's in there right now. We have a protocol that we established with the Huskies here in Seattle. So he's doing gentle stretching, biking, no bracing right now, and the beginner core exercises. And that's kind of our protocol that we published recently for our athletes that undergo this type of surgery. So doing really well. So here's a fellow, the first endoscopic spine fellow we had, Dr. Saqib Hassan, superstar, really pushed me, made all of us much better, by really being, very, very involved in this. And he's now in California, really an upcoming superstar. And he wrote this paper, we looked at this benefit area, and the idea is original from Dr. Hartle. Where is the benefit of MIS and in relation to the complexity? And for a discectomy, I think, there's an incremental benefit of using endoscopic technique. Again, there's so far 3 prospective randomized controls trials that have shown that. So the data is the highest quality data that we have. And the difference is, there's a difference. And I think if you have enough number and, high enough number of cases, you're going to see a difference. So the complication rate is 10.3 versus 13.4%. And so that's real. It's just marginal. And with a low complexity case, it's a hard argument to make. But that changes with more, if you go up the ladder on complexity. So a little bit like the same as cars, the low end is kind of the same, right? But once you go up to the higher levels of vehicles, then it really starts making a big difference. And so one of the procedures that is more complex, albeit not super complex, is like, for example, a laminectomy just happens to be a very, very common procedure. And so again, we described that both of the AO as well as in the TIMI book that we published, the different steps and approaches. Again, it's a very, given the narrow working corridor, you have to be extremely precise. So there's not like the normal spine surgery where you can muddle through. You just have to really, every step needs to be well thought out and be very well planned. And so you go there, for example, here's another example, a 56-year-old firefighter had this 1 year of progressive intensive shooting pain in his lower back, bilateral buttocks pain, muscle cramps, and he feels weak when he's hiking. And on exam, he had gluteus medius weakness. You can see his pain diagram. I mean, he was not a happy camper. A lot of lower extremity pain, and rates his buttocks pain as 10 out of 10. So really not doing well. Slim firefighter in good shape, otherwise still working. Those are the options, right? I mean, you just do a laminectomy. Some people are going to put a cage in there, and you can do it indirectly decompressed, which is a little bit aggressive. Probably you can do TLIF. And in this case, we did a ULBD, which is a over-the-top decompression type surgery. So here's some surgical impressions. ULBD, you can see a couple of impressions. So again, here's rostral on the left side, caudal on this side. Here's the attachment of the ligament, which informs the entire bony decompression. We strip off the ligament, with a sharp dissector up there, and we're progressing quite nicely in the surgery here right now. see that. Everything is good. Music is playing. It's the 10th Zoom meeting of the day. So, and everything is fantastic until we come to this, right? And so we keep going here and we take a bite, lateral recess decompression, right? And so very carefully, maybe not carefully enough, bite. The bite doesn't come very easily. And then here we go. And in the back we have, you can see it in the back here. So ripping out a piece of dura, you can see it stuck there. So fantastic, right? So now we have it here. Dura is open. So here's the, I think there's one video in between. Now here we got that. So here is, actually, I think I might have, sorry, I think there was in the end of the video was just showing the extent. So the most important thing is when that happens. So we have a dural opening there, a dural laceration. So I always like to, if possible, always like to, continue the surgery. There's no reason to kind of freak out. So you can see the nerve root here, the arachnoid, and we keep working. We keep doing a lateral recess decompression, right? It's this, we have that opening, and obviously at this point now you see that I'm a little bit more careful. I'm obviously, shaking here, not really, but maybe a little bit. And so we continue to do our surgery. As you see the opening here, nerve roots are coming out, which is always a fantastic view. And there's no audio for a reason here. Then we go. And so here's how we repair these. So here's the opening. Again, at this point, everything is decompressed. So we are around the thecal sac, lateral recesses are decompressed. You can see the opening arachnoid coming out, nerve root there. And so we have developed a bimanual technique to do inlay grafts for these that are secured with this seal. And for a defect this size, which is probably 3-4 millimeters or so, that appears to be working very well. So again, achieving hemostasis here right now. You see that area here right now, and we bring in our second manual sort of thing. It's a bent K-wire that we bring in there, and you'll see why we need that for. So a piece of Duragen comes in. I like to mark it on one side so that it's asymmetric typically. So bring that in there, and then you wedge it in there with your second hand there, and again, it's wedged in there, rotate it in there. Again, it's a little bit, obviously, as you can imagine, not super straightforward to do that, but technically feasible. So you have a blunt dissector here, bring it in position here right now into that defect as an inlay graft. And then we have the second instrument coming down in a second, wedging it in and holding it in place while we glue it with the seal. So here we tuck it in, tuck. Perfect. And now the second tool comes down. We'll just put it in there because irrigation typically floats it out. So now the second tool comes in bimanually. We put it on there, hold it in place. And then at this point, we bring in, again, it's always gilding the lily. There's always a little bit that can be done better. This little edge that I wanted to tuck in there. Go, tuck it in there and hold it in place. And then you'll see soon 2 long spinal needles coming down there, down the working channel. And then we're going to put some to seal down there. They should be coming down any second here. Here are the 2 needles. And then you kind of glue it with to seal that is going to come in there in a second here.
Hey, Christoph, can I interrupt with a question?
Yeah.
And thanks for showing that video. Obviously, that's the #1 question that people ask. What do you do if you get a CSF leak and you're showing what you're doing?
Because I can
question that
smell, I can smell what you guys think.
Yeah, that always comes up. So you may touch on this later. I'm sure you will, but I just want to ask it right off the bat. So a lot of people wonder the learning curve. The learning curve with endoscopy obviously is something that's challenging for many, including me. What is your take on that? I mean, I've seen videos like this dozens, maybe hundreds of times, and I still can't really tell what's top, bottom, left, right.
Yeah.
What is the true learning curve behind this? How many cases does somebody have to do? If we have somebody from the audience here, from the participants who really wants to pursue endoscopy, what is the honest, transparent, advice that you can give them to get to a point where they can do what you're doing? Even here, we're not even talking about endoscopic T-lifts and things like that, but LAMIs, discectomies. Can you just give us a summary of that real quick?
It's a great question, Ali. Thank you. Actually, right now I have one of my residents, Sanan, working on this, and in particular, exactly what you ask is, what is the learning curve of an interlaminar versus a transforaminal versus a more complex operation, like a not that a laminectomy is complex, but it's just a lot of stuff that needs to be done there with such a small working channel. So my answer to that would be, again, endoscopic spine surgery is not one procedure. It's like, we do cervical, thoracic, lumbar. I did an endoscopic T-lift yesterday, which is getting to, I think, parity to MIS. I think if you're not trained on it and you don't do a fellowship, it's going to be a protracted, course. What I've seen, it takes typically 2, 3, 4 years to slowly sort of like, work your way into it. Typically, I've seen people in mid-career and career that sort of get started where we do cadaver labs, typically 2-3 weekend cadaver labs, and then you're comfortable enough to do like an L4-5 discectomy, a transforaminal, which is simple because, you don't have to have, the endoscope kind of wedges into that foramen, and then you don't have to worry too much about handling all the tools. And so that's reasonable. L5 is one. The first cases I showed were pretty simple cases, except for that they have a very large discs. So I would say, 2-3 weeks of cadaver, so 2-3 weekends of cadaver courses, and then sort of slowly build your skills with, doing 20 simple cases and slowly advancing, because this obviously as your first case would probably make you never ever do this again. Now the issue is for us is like, I think, with this technique, we can really sort of manage, I've never actually opened the patient up for a dural tear, never, because, even the worst, I have 2 outcomes that had worse outcomes than I would expect otherwise, 2 patients. But I didn't open them up because a year afterwards, they were still probably doing the same as an open laminectomy. That just, the classic kind of like outcome. And so, for example, so I think learning curve depends. I mean, if you want to be fast and really sort of make this part of your practice, I would encourage you to kind of go somewhere for a couple months and really sort of scrub in and learn it. It's a lot of, there's a lot of, nuances to it. I have the amazing fortune right now that Dr. Kashlan is with me right now, and he's from the University of Michigan, who is an amazing doctor and surgeon, and he's spending 6 months with me to kind of learn all the nuances. And honestly, I think the best thing is to contact one of my fellows and just get a real estimate, because I think we all kind of like, I think not very unbiased. We're all biased in that response, but I think it's 20, 30 cases. I have a number of 15 afterwards on one of the slides, but there's a learning curve for sure.
And thanks for that. And that was going to be my follow-up question. You said you never had to convert to an open for a CSF. Like, have you ever had to convert to an open case for any reason?
I have had a couple cases where I had hematomas that came back, and again, the decision-making, I have another talk on this, but the decision-making of a postoperative hematoma is with MIS and endoscopic is not a radiographic one. The decision to go back to the OR, as you know, is kind of neurological symptoms, and the MI is only to determine the spread of the hematoma. And so I've had hematomas that needed to be evacuated, and so those we've done with open surgery. And we've had 2-3 cases. Luckily, since we're using now flow seal after these procedures, so whenever I'm done with a laminectomy, I fill up the cavity with flow seal, and then I'm waiting 2 minutes, which is so freaking painful. 2 minutes of waiting. Oh my God, I hate it. But it's I think it's worth it. But it definitely teaches you patience.
Thank you so much for that.
So here is that repair. And again, that's his outcome. He's 6 weeks out right now. Before this talk, I just want to make sure he's doing okay. He sent me this email. He apologized for a slow response, which I thought was unacceptable. Patients need to, respond immediately. But he's saying his back is functioning very well. The same patient that we saw before, leg pain and back pain is gone. I rock climbed for an hour and a half on Monday. I feel no extra pain in my back during or after. Here's his follow-up. Again, he's still paper. We recently switched our follow-up to app-based electronic follow-up, but this is just old-fashioned here. So I think these repairs work really well. But again, if you cannot make a good inlay graft, and you have I think I had also the good fortune, if you noticed, that the arachnoid was still intact. And so with an inlay graft, I think we're doing pretty well, for sure. And then one thing is, it's not the same patient, but a different patient where we did an L3, L4. What I love about these patients is you can see the decompression here. And you can, with the endoscope, you have a fantastic preservation of the facet joints. And then here's a couple of studies, and I'll go over this very quickly because I have a couple of other nice cases, and I want to be respectful of your time. So this is basically for laminectomies of the best trials that we have right now, complications. And so, we have the trial, the Swedish trial for the, fusion versus non-fusion for spinal stenosis. And again, just looking at the complication rate, there a 29 rate of complication in the traditional laminectomy group. Dr. Benzel's SLIP trial, again, not too many patients, but a really well-selected prospective cohort. Again, the highest quality we have, 40% complications. Again, nobody in this group here ever would admit that you have 40% complications with laminectomies. I mean, I would also tell anybody that's crazy. I mean, I just signed up an open laminectomy patient up right now. I did not tell him that there's a 40% chance of complications. But again, in the best data out there, that's kind of what we have there. We did a learning curve paper at the beginning where we compared MIS with endoscopic. Not surprisingly, surgical times were longer for the endoscopic cases. And you can see, I mean, it was, we were really slow at that point, 3 hours at the beginning. So that's what it took us to do one level, which is absolutely, obviously, very long. But again, all the stuff that we have worked out and all the protocols didn't exist at that point, and the tools, neither did the tools. So now we're down roughly to an hour per level. But again, from the very beginning, the hospital stay with 0.7 compared to 2.4 was quite remarkably lower. We also found that, lower extremity pain scores were better. And I think it's because you get a better and a more precise decompression. But again, there probably needs to be better studies on that. And then here's what in our cohort, what we had there is with minimal invasive LAMIs, we had a 26% complication. Again, including everything, duotomies, urinary retention, paresthesias, reops, and dual BDs, we had 8%. So markedly better. In this cohort, in the first 50, we didn't have any dural tears. I guess that comes later when you become more of a cowboy. And then here's other studies on endoscopic ULBDs. So patient by Dr. Comp, as a study by Dr. Comp, 14% complications. Patient, a study by Dr. Park, endoscopic ULBD, 11% complications. Study by Dr. Chen here, 3.7% complications. And so putting all of this together again in this benefit paper is like we are looking at a 34% with traditional versus 9% endoscopic complication rate. So putting this on this graph, a more complex procedure, the benefit area is much higher. So, and that is very, very obvious from the second you do these cases. And again, I would, it's easy. Just have to. It's a very, very obvious difference. So a couple of things about high complexity cases. So cervical and thoracic, where these are really game changers in my mind. Here's like, for example, a thoracic discectomy. Thoracic discectomies have gotten really simple with this. Again, retropleural approach used to be my most favorite procedure. Again, we don't do those anymore because with the endoscope, it's more precise, much less morbidity, and you don't have to drop the lung anymore or sort of into the pleural cavity. It's a totally different type of invasiveness. Here's an example, T12L1 disc herniation on this 66-year-old female. You can see the pain diagram here, but what mainly she was bothered by was progressive gait unsteadiness and numbness of her feet, and you can see the tip of the conus, so it has T2 signal changes. Exam, she had plantar flexion weakness 2.5 out of 5 and unsteady gait, and you can clearly see the impingement of the tip of the conus. And so what we did there is an endoscopic discectomy, and again, it's very, very simple to, technically very easy to put a cage in there. In the thoracolumbar junction, it's really my go-to for one segment fusion. It's really my go-to procedure because you don't need any lordosis there, and the current technology can really support that very well. And this patient is doing well. One more little bit of crazy case, because it's always fun to look at crazy cases. A delightful 45-year-old female that I was fortunate enough to be part of her care. Treated really rough by life. I mean, she's ankylosing spondylitis. Everything hurts. She had this chance fracture. I think it was 3 years ago, where she had a construct placed that you should not do. For anybody who's a trainee here, this is not a construct you should do for somebody who's ankylosing spondylitis. 2 screws on top, 2 screws on the bottom, no interbody support. I mean, you might as well not do that surgery. So that's obviously failed, and it failed really badly. As you can see, she's standing in my office here right now, and you can see that spot of fluid here right now. It was CSF leaking out of her back. She had multiple revisions, and down there you see on the CT scan here, the pedicles, everything is just hypostotic. So it's a true Charcot kind of type joint, absolutely miserable and in pain. And you can see that here. So rates of pain is 9 out of 10, and like you see the graph there. So leaking CSF. And so what we did there is, we did a decompression of that area with the endoscope. Not surprising, getting in there, you can see that you're drilling down the pedicle, drilling down part of the vertebral body. And doing this approach, we're looking actually here at the spinal cord itself proper. You can see the hypostosis right in front of the spinal cord. And then cleaning this off here right now, trying to find that edge of the dura, right? That Charcot joint has worked its way through the dura. There was just really nothing there. So here's the edge of the dura here, of the intact dura, and here's spinal cord proper here. And so you're drilling this bone away from the spinal cord and decompressing everything. So keep going here. Here's the sleeve, spinal cord here. And we kept working here. Reconstructing the defect of some duragen. Again, if you do this case a retropleural, then you're going to have a lot of fluid in your drain if you do that retropleural, because obviously she has no dura there. So CSF leak was luckily not an issue for her. I have to acknowledge, in this case, we did have, I've never had this before, we did have in this case, we had a postoperative pneumothorax, which was because I left the cannula in there when I put the graft in, and it sucked in air. There must have been erosions of the parietal pleura there too, because everything was eroded. Not only the dura, probably also the pleural. So she had a pneumothorax that we had to treat. But besides that, she did very well. So as you can see on those images, we were able to drill down the pedicle, drill down the ventral osteophytes, the marginal osteophytes, and circumferentially decompress the spine there. Again, I don't think there would have been a better way to do this case, and it's this kind of type of pathology where you can really help patients that you were not able to do so meaningfully before. And so this is the end of the last point of the presentation, and I'm going to put away my nice doctor hat right now, because now we're looking at value, right? I mean, like in the real world, why the heck would you do 30 cases, buy equipment? Why would you do that? I mean, it's a lot of work. You know, there's really no appreciation, while our skull-based friends make twice the money doing endoscope-assisted surgeries. Everything we get is that this is experimental surgery, which is obviously a piece of garbage, but that's kind of what we are told we are. So what are the pros? Well, increased productivity. You know, you don't have to round on your patients because most of them go home. Favorable patient outcomes. I have a prospective randomized control trial going on here with open versus endoscopic laminectomy. Guess who gave me the most grief? It was not the IB, it was actually my clinic staff that didn't want to see open laminectomy patients anymore. So my clinic staff actually was the most outspoken against it. Our ergonomics, it's a pro, but not like crazy. Con is learning curve and capital investment, right? So, you know, shorter hospital stays, definitely a plus. You know, my service, since I do, you know, roughly 40-50% endoscopic, is always half of the size than it used to be. Lumbar discectomy 0.7 versus 1.4. Laminectomy 0.7 versus 2.4. Anybody who's younger than 70 years old typically goes home. If I have a leak, I keep them overnight flat. TLIF 1.4 versus 4.8 days. So fewer patients in the hospital. We talked about the complications. Favorable patient outcomes. I'm not going to go into all the papers here right now. I think there's a lot of data that it's better. Ergonomics, you know, it's definitely nicer. You don't have to move the scope around. I think, you know, when I do a tubular decompression now, it's, you know, moving, rotating the bed, you know, having the metrics tube in place, bringing the microscope in. Those are all things that you easily forget, you know, when you sort of, that you don't have to do with the endoscope, because it's just in your hand and you control it. Learning curve there's a couple of papers on that. So they say, you know, 10 to 15 cases. And I think that's probably what you can do in 2-3 days of cadaver courses. And then with some guidance, you can slowly work your way up for sure. And I've seen and worked with, had the good fortune to work with a handful of amazingly talented surgeons in the US who have picked it up during their career, and I'm super proud of all of them. It's been really fun to get to know people, and actually during the time I've actually learned a lot of things of other, you know, surgical specialties, you know, of other sort of procedures that you kind of exchange then and learn from other people. So it's been really really rewarding. Capital investment is roughly $400,000, and which is less than an operative microscope. Here is, you know, non-instrumented endoscopic spine surgery is cost-effective. Lumbar discectomy endoscopic is $24,000 per quality. A traditional is $34,000 per quality. So incremental benefit, again, like discussed before. Reimbursement now, all codes, you know, as long as you are using continuous optical visualization as an accepted mode of visualization. So my understanding is that all spine codes that we can use that. You don't get paid for the microscope, you don't get paid for the endoscope, they don't pay you for the loops. And again, that's in the CPT book where I got that from. So now what's the value proposition? And again, this is a slide actually that I got from my mentor, Dr. Wang. You know, endoscopic is, you know, hospital stay. They're both, you know, short, but, you know, incrementally better with endoscopic. Low cost procedure. They're both not that expensive. Both can be done as outpatients. So now we're talking about non-instrumented. They both have not good reimbursement. Microscopic is taught, during residency. Endoscopic is coming, but not as frequently. Disposables, endoscopic, even though we looked at our costs between microscopic and endoscopic, and the costs are actually very similar, because even with the microscope, you need a microscope drape, you need other drapes and stuff. And so the disposables are actually remarkably similar between those different procedures. And again, I think Mike Rang really has understood that, what drives the market in the U.S. I think, and that's why he's pushed it so hard. And I think in terms of introduction to the market, I think he's right on. I think his fusion procedure can be more standardized. I think the merging an arthrodesis procedure with full endoscopic technique is technically much easier, and it combines the advantages. You can treat a wider range of pathologies. And the interesting thing is, once you use an endoscope for fusion procedures, actually, in fact, instead of incremental changes, you really have dramatic changes. And that is going through the literature, very obvious in the literature that Dr. Wang has published, in that a traditional MIS TLIF cost was around $80,000, and an awake endoscopic TLIF now costs him $20,000. And so there's $60,000 difference, providing the same code and everything. And so, in the end of the day, money is not everything, but it appears to be everything in medicine. And so I think that's why, I think if this becomes accepted or not in the US is going to be most likely going to be decided if it's going to, result in good outcomes of 1 and 2 level arthrodesis procedures. And I come to the conclusions here right now. It's endoscopic spine surgery minimizes invasiveness. It achieves similar outcomes compared to traditional surgery, but has a lower complication rate. Endoscopic surgery for segmental arthrodesis procedures has a potential for dramatic cost savings as the technology evolves. And I say that with a very, again, in my practice, technically, a very simple procedure is an endoscopic TLIF. And again, I do it quite routinely for the thoracic and the thoracolumbar junction. And I think technology currently evolves to provide meaningful degrees of lordosis, so that this is no doubt going to be, it's very soon going to be a meaningful alternative for MIS TLIFs. And again, the tools and the adjuncts, such as navigation, are going to help to make it more mainstream. And so I wanted to thanks everybody for listening. And if you have any questions, then we can do it right now.
Great, wonderful. Thanks so much, Christoph. That was excellent. Obviously, a very, very challenging and difficult kind of technical skill set that you and others have mastered. And thank you for pushing the envelope and advancing our field. It doesn't matter what some of us do or don't do, or like or don't like or don't enjoy. It's just, I think, good overall for our field that there are pioneers and innovators, because that's just better for everyone. A question from the audience, Dr. Singh. He wants to know, on one of the cases that you showed, there was a dural defect preoperatively. He wants to know how you identified that. Did you do a CT myelogram, or was it obvious on the MRI? How did you identify that dural defect?
Yeah, so does he mean the laminectomy where we kind of like have the defect? I think that was iatrogenic. I think I grabbed that with the kerrison. But let's blame the patient. I'm all for it. Thank you. It was probably there before me, so I like it. Thank you so much. Appreciate that. The lady with the Charcot joint had a dural tear because they had oversewn the wound multiple times, and she was leaking from CSF from her back. So it was a clinical diagnosis that the dura was missing there. And again, we see that quite a bit, with those type of joints that they just erode through everything, like the pleura. And I think that's why we had a pneumothorax there too, because I think that all the membranes at this area was just eroded. So I think, to that question is like, as we've all have seen, like if you have an, 80-year-old person with a grade 1 slip and severe stenosis, you can, probably anticipate that the dura is going to be a couple of cells in diameter. And so, yeah, sometimes it's just unavoidable. But for most part, we can repair that quite nicely.
Wonderful. A question from any of the faculty or panelists? Michael, do you want to chime in and ask a question? Or anybody? Alex?
Yeah, I have a question. It's a great talk, Dr. Hofstetter. Alexander Mamigani from Switzerland talking here. I have a question. You are a neurosurgeon. Could you transfer your skills, your surgical skills from endoscopic skull-base surgery to spinal endoscopic surgery? And do you have orthopedic fellows as well who have lots of experience in arthroscopy, and could they use their skills? Do you see a difference between orthopedic and neurosurgery in endoscopic spine surgery?
Great question. Thank you. The transnasal surgery is endoscope assisted. So it really is just, basically, you take down the septum, you have an endoscope that is not a working channel endoscope. So the tools are more traditional with loop curettes and like, pituitaries, suction curettes and stuff. So I think the trick with the working channel is that you're constrained in your axis, and so it is technically a little bit different because you have basically 3 moving parts. You have a working channel as a working cannula that is your retractor that creates an artificial working space. You have an endoscope and you have a tool, and that you have to manage with one hand, and it's a little bit like riding a bicycle. And the great thing nowadays is that we have really a good teaching protocol together. With other words, we know how to hold the scope the most efficient way. How to rotate it, what tool to use. There's a lot of things. The last 5 years have been really, really productive in terms of standardizing and teaching this. So I think it's that a lot of change. And then to your change of ortho versus neurosurgery, I work very closely with my ortho fellows together, and actually one of my very supreme fellows here, Dr. Saqib Hassan, who was really, he really challenged me and pushed me. Again, as we all know, I mean, the fellows, they push us and they drive us nuts, but they do make everything better. And I cannot say enough good things about, as painful as it is in the moment, it's like children. In the end, you're thankful for it. And so he has really helped to advance the field quite a bit in that he brought, orthopedics principles into my OR. And so we work very closely. So I think the orthopods have a slight advantage because they're used to not that you need triangulation, but they're used to working under irrigation. And so I think it's a pot there. I think there's neurosurgeons, we know the neural structures better. So, I mean, I always kind of got a little nervous when he was like ripping on the nerve roots, but, when it came down to the bone work and, using the tools, I think orthopedic fellows are very, very good. So I think as always, I think neurosurgery and orthopedic is a very complementary and a lot of respect for each other.
Dr. Hofstetter, I have a quick question for you. What are your thoughts on utilizing endoscopy for foraminal decompressions in patients with degenerative scoliosis? I know there's a big push globally about, lateral fusions, O-lifts, D-lifts, getting indirect decompression, but do all these patients really necessitate a fusion if they have no back pain and just leg pain? Can we take care of this through endoscopy?
Great question. Awesome question. The thing is, that I'm sure you guys have seen, some really good talks where people have like these graphs that are really explain something. And so one of the talks that I've seen is like when they talk about, new technology and how you use it for everything. And then afterwards, you kind of like, you realize that it's not like God sent so much after all. It's like, again, it's just like incremental as everything in life. And so once the honeymoon phase is over, then you run against the wall. And I think I would say that one thing that I've ran against is like the foraminal, I call it the vertical foraminal stenosis, where the pedicle to pedicle distance is less than a centimeter. And I've drilled down half a pedicle, drilled down end plates, marginal osteophytes, and you can get a patient asymptomatic for like a half a year, but almost all of them come back within a year and the symptoms are back. So, I think that's kind of something that we as a field have to redefine. I think that's really where I think mechanical back pain comes from, is really a structural mechanical insufficiency of the foramen to protect the nerve root. With other words, I do many more A-lifts now than I used to do. So if you have an L5 is one, especially the coronal deformities, the segmental coronal deformities, where one side is collapsed, sure, I can spend 4 hours to drill out part of the S1 pedicle, but at the end of the day, this patient is going to be back and typically not very happy because there's a good chance that you irritate the nerve root a lot. So those things I don't attempt anymore. So if you have a segmental coronal deformity at L5S1, one side collapsed, modic changes on one side, L5 verticulopathy, it's an ALIF or like an MIST lift if the patient has a contraindication. The same for, and I see these images of my colleagues that post, scoliosis patients, and you drill out the foramen. In my hands, again, really following these patients religiously, after a year or two, the pain is back typically. So I think we have to define this better. But the idea in my mind, and that's my opinion and my expertise, in my, let's say you have a fractional curve at 4-5 and the patient has an L4 radiculopathy, just going in there and drilling out some part of the, 5 pedicle, it just gives you a very temporary relief. And it's a structural issue. I think it's a mechanical problem, and you can't just decompress that. So I've definitely run against that wall, and we should probably define that. I'm actually have a couple of students working on this right now, is because I think one thing that endoscopic spine surgery is now teaching us, I think we can really identify the patients that need a fusion, like a T-lift, patients that need indirect foraminal decompression, because the decompressions are so standardized now that, if you do it this way, you cannot roughly get this decompression. I think it's actually going to hopefully help us to really say, hey, this patient with a grade 1 slip and bilateral foraminal stenosis needs a T-lift rather than a decompression. And hopefully we can standardize it so far that we can not have these stupid insurance battles going forward. So I think it's honestly going to be exactly the opposite. There's some surgeries that just need to be fused, and at least in my hands, having tried this, I've done at least 20 L5S1, L5S1 collapses, and 80% of those have had fusions that I did afterwards. So patients are not upset about it because they're like, well, doc, you tried it. But, on the other hand, I mean, there's only so many heads you have to run against the wall.
Oh, thank you for sharing that. That's a very important piece of information. Thank you.
Yeah, no, absolutely. Yeah.
Hey, Christoph, thanks for joining today. I'm curious, as really sort of the, one of the premier people in the world.
Man, I'm not going.
As really one of the premier sort of endoscopic, spine surgeons in the world, where do you see sort of the ceiling capability of endoscopy? Like, what will be the most that we'll be able to accomplish with it? And are we there, or do you still think we have a ways to go?
I think, I really admire a lot of people in the field that, really have vision, like Mike Wang has. I think he has the right vision, and he understands why the field is going the way it does. I think, there is, a lot of potential still. I just have seen it the last 5 years. I mean, again, you saw the operative times. I mean, my first laminectomies were 3 hours per level. I mean, that's 17 IVUs for 3 hours of work. I mean, that's crazy, right? Again, the place I work at is, you're not appreciated if you work a lot, or appreciate, it doesn't matter because it's so dysfunctional. And I think we have developed it to something that is meaningful. But I think the decompressions, there's still another 30-40% efficiency. My goal is to get the lamis down to 35 minutes or so. and we have ways to do that. I think the next big milestone is going to be endoscopic lumbar fusions that I could show in this meeting without being beheaded. And so that's a good thing about Zoom. You can't behead anybody. Actually, I guess you can. The Zoom bombing that I do graphically remember, there was some beheadings. Oh my God, this is disgusting. And and so I think the technology is going to be for the 1 and 2 level fusions and the benefit for the patient are going to be just you can do it as an outpatient procedure. And so I think that's the next technology. Dural closure devices, so you can do some intradural work, is I think also feasible. But I think it's a good adjunct for a lot of things. But I think there's another 30-40% possibilities that we don't know for sure.
Great, wonderful. Christoph, Coy, did you have a follow-up question or a follow-up comment? The real Coy.
I did not know.
All right, wonderful. Well, so we stay on time. Dr. Hofstetter, thank you so much. Always great to have you, and welcome back.
Be a doppelganger today.
On behalf of the faculty and the panelists and the participants, thank you for doing that today. Next Thursday, we're shifting gears a little bit. Our guest is Dr. Chris Bono. Chris Bono, he's an orthopedic surgeon from Mass General Hospital. And the topic will be adjacent segment disease in the lumbar spine, adjacent segment stenosis and listhesis in the lumbar spine and how to manage that. So that's our guest next week. Dr. John Shin, who was unavailable today, will be hosting. Until then, thank you, Christoph. Thank you to all of our faculty, panelists, and participants. We'll see you next week.
Thanks for having me, and feel free to reach out to my email anytime if you have any questions.
Thank you, Christoph.
Thank you.
Take care. Have a good night, everyone.
Stay safe, everyone.